Hi, everybody. So I live actually in Bloomington, Illinois, which is about 2.5 hours south of here. And my trek north was beautiful and fantastic until I hit Lakeshore Drive. And then I remembered why I no longer live in Chicago. However, you'll notice as I continue to speak and as I've been talking to some of the lecturers today, my Chicago accent is coming back. Even that Saturday where I'm saying that, it's coming back. I'm in a land now where most people are Cardinals fans, not Cubs, so we'll forgive them for that. So yes, I'm going to talk to you a little bit about DVT prophylaxis and current trends and some of the interesting facts as I was looking at this. First and foremost, I know most of our hospital systems probably have a DVT PE protocol. However, statistics have been showing that not a lot of our facilities, and even us as surgeons, aren't following these protocols in the way that we should be. So we'll be talking a little bit about things we can do to protect our patients and to protect ourselves. So this is me. I'm going to continue on right there. There we go. Here's my only disclosure. Those are my two cute kids. I'm on the Speakers Bureau for the American Board of Podiatric Medicine, so I'm really excited to be speaking to you guys today about medical management of our patients as we treat them for surgical issues and even non-surgical treatment of things like these fractures. A huge thank you to Dr. Yeager, Dr. Lehrman, the ASPS board, and Dana. She was super helpful with me getting slides together for this, so thanks. So background, let's talk a little bit about DVT. So both DVT and PE, they are relatively common. They actually are seen probably about 20% of patients. It was interesting. I think almost 80% of us raised our hands of having a patient that's had at least a DVT, and several of us with a patient with a PE. Prevention and or immediate treatment of the DVT is the most critical component with respect to this. If we can prevent it from happening, obviously those complications are huge. However, once the incident happens, if we can prevent it from becoming a PE, that's where that mortality risk comes into play. So the combination of the two, DVT and PE, account to almost 100,000 deaths in the United States each year. So the Virchow triad, this is board's question. So the three components to it, venous stasis, which includes immobility and CHF, endothelial trauma, which is what we do. They either got hurt or we did a procedure on them, and the hypercoagulable state. So they either have active cancer, they've got thrombophilia, they've got OCP, something is causing them to actually be out of balance. You don't actually need to have all three to develop a DVT. In fact, the most important factor of those three is the venous stasis component. And in addition to that, the highest risk patient is simply the one that's been hospitalized, no matter their weight-bearing status. And that's really because when they're in that hospital setting, we inherently want them to stay put. We have all those patients with fall risks and other issues and things. We're requiring them to stay, in essence, bedridden, and that puts them at a higher risk for blood clot. So I mentioned earlier that a lot of patients, or a lot of hospital systems, most of them should, have protocols for prophylaxis for DVT and PE. Up to 50% of hospitalized patients, and this is a study from 2017, aren't actually receiving DVT prophylaxis upon admission for whatever reason. Either it was skipped when they came in through the ED, or they were a direct admit and something didn't happen. But that lack of communication and the lack of responsibility on the medical team's part is what's put them at huge risk. So one of the largest risk factors is simply being hospitalized. So what we want to target, two main things. Venous stasis, so we're using mechanical methods for that, various ways that we're compressing them, either with weight bearing or non. And then we want to address the hypercoagulability with pharmacological agents, which we'll talk about some of the more popular ones and when one would be used versus the other. So why do we want to prophylax it? I've already said this twice. They are the most common the most common cause of preventable death in hospitalized patients. And they're at a high risk for us when it comes to medical malpractice. We need to be aware and vigilant about taking care of these patients and assessing their risk factors. So the primary way we would do that, I said this before, you're either going to use medications and mechanical components, or after we've seen an instance, so this happens, I think It happens to all of us, where you're noticing something and you're concerned about risk of a DVT for a patient, treating them even on a subacute basis with oral anticoagulants or even with low molecular weight heparins. So an anatomical review, why does this happen? Obviously, we know the lower extremity venous supply. The two most common veins that this would occur in are the superficial femoral and the popliteal. They're in the back of the knee with that flexion extension. There's the most likely chance that something's going to get stuck there as things are heading northbound. That's actually often my joke to the patients. I'll comment to them about how our toes are Miami and our heart is in Chicago, and that they have to head northbound, but they get stuck in Atlanta, behind our knee. They're getting stuck there, and it's a major issue, and it's one that we need to be considering as we're treating these patients and performing procedures on them, or simply immobilizing them for these stable fractures. We need to be paying attention to it. Now, upper extremity, not as common. You won't actually see this, but the subclavian vein is the most common, and that's because of the horizontal or the east-west orientation of the vein itself. There's a increased likelihood of someone having some stasis in that area. Okay, so I actually really liked Dr. Bellis's picture of the smoker lady, but here's my gentleman. We all have this gentleman, right? Increased risk of DVT. All of these matter, and usually we have a combination of all of them. So no matter what, if someone is greater than 70 years of age, they're at a higher risk and they must be prophylaxed against, even in a weight-bearing situation, which we'll talk about. Immobility, whether they're traveling or if we're limiting their weight-bearing status. Typically, a traveler simply has to wear 15 to 30 millimeters of mercury compression hose, and they should be fine as long as they're getting up on the plane once every 30 to 60 minutes. So we really need to talk to them about these travel things. One of my 3 instances of having a patient with a DVT happened with someone who was weight-bearing post-operatively 6 weeks post in Austin. She was completely fine. She traveled to Hawaii and got a DVT on the plane. And again, it's just about that communication with our patients and making sure that we're aware of what they're doing because they're not paying attention to it. A personal or a family history of DVT puts them at increased risk. ICU admission above and beyond simply a hospital admission. Stroke with lower extremity paralysis, that makes sense. If CHF is advancing, if they've got active cancer, and this is any type of active cancer because that puts them in that hypercoagulative state. Acute respiratory failure, thrombophilia, recent surgery or trauma. It doesn't matter how good our hands are. It doesn't. It doesn't matter that we never touch them. We just immobilize them. The fact that they've had trauma or an endothelial injury or that we've performed a procedure on them puts them at high risk, as does obesity. I know Dr. Bellis just mentioned that when it comes to these non-unions, but we really need to be having these conversations with our patients about the fact that they're overweight is causing them to have higher risk for these problems. And then this ongoing hormonal replacement therapy, that includes females with oral contraceptives. Okay, so every single hospital has one of these. This is just Northwestern's, because I figured we're in Chicago, let's look at Northwestern's. But so many of these have just minute risk that adds up and gets calculated. So they base it off this Caprini system, and if you look at the left-hand side, there's a risk factor that just equals 1 point. All a person needs is 5 points in order to have to be mandated to be prophylaxed. So anybody that's greater than 41 years of age, I am not there yet. I'm really close, I'm not there yet. Minor surgery planned. And when they say minor surgery, this is anything. This is us excising a soft tissue mass. This is a upper extremity surgery. This is any type of endothelial injury. History of major surgery, of course, of less than 1 month. If they've got varicose veins, history of inflammatory bowel disease, swollen legs, obesity again, acute MI, CHF, serious lung disease, like pneumonia recently. I mean, this is the low risk category. I think almost all of my patients actually fall into that. And when you go into the higher risk, age, obesity, family history and personal history of DVT, we really should be paying closer attention to this, even in patients that we're allowing to weight bear after surgery. Okay, so when we're assessing this risk of thrombus, there's a couple of things. Now, a lot of these studies will actually talk about this age, and there's no real finite line of it's safe. Some studies will say younger than 40, some say younger than 50. Many of them simply say young patients, and I don't really know how they would define that. So if they've got a risk factor of any kind, in addition to being over the age of 40, I'm going to prophylax them at this point. But if they don't, then you really don't need to do that. You can actually even possibly work with those mechanical components after procedure. Moderate risk, it just takes 2 risk factors. That's it. Actually, really greater than 1. You have to make sure you're doing some sort of prophylaxis immediately post-surgery, and you might or might not do the mechanical prophylaxis depending on their weight-bearing status. And then high risk, anybody with greater than 3 risk factors, and going back to those, I think it's that way, yep. Almost all of our patients have 3 of those. I mean, they have something going on, so we want to make sure we're paying attention to it. We have to make sure we're doing both, that we're treating them pharmacologically and that we're treating them mechanically. Okay, so what agents are we using? First, the preferred drug due to dosing is something like a Lovenox. You want to use those low molecular weight heparins, and a lot of times you can actually, if it's a planned procedure, I'll talk about this in a few minutes, but you can actually start those pre-operatively up to 6 to 12 hours. In patients that have really poor renal function, you have to use unfractionated heparin. And then some patients you need to be careful with, and you would use the fondaparinux. I don't use this very often, but it doesn't inhibit thrombin. So that's another concern that we want to be aware of. Okay, when do we use it? What should we do? Any type of orthopedic surgery. At least 10 to 14 days. And they're saying in many of these studies that you want a month. You want greater than 35 days from date of procedure, even in the absence of other risk factors. Who's doing that right now? I wasn't either. I'm like, really? We should be doing this? Are we even doing 2 weeks? I'm doing 2 weeks. I definitely am. Who's doing aspirin? Right? I was too. I was like, oh my gosh. So it's definitely something. My mom, she fell in early June, so she literally could be Dr. Bellis's patient. She's 71-year-old smoker. It's awful. She had total fracture dislocation of all of her bones in her right metatarsals, and she, it looks awful. She's total non-union, but they put her on aspirin afterwards, and I'm like, really? Like, what are you doing? So then we were speaking with her surgeon and things like that, because of course it went through a downstate emergency room, which we don't have the same kind of sophistication as a Chicago emergency room, I will say that. So she's now on Lovenox daily. However, it's been almost 60 days and she's still struggling with some things and she's still at high risk. Onset of use, we have to make sure that we're using this medication in an appropriate setting, but also in an appropriate time frame. They have to be started within 12 hours of surgery. What this doesn't say at all is the weight-bearing status. Even if we're walking these patients, even if we're doing an elective lower extremity surgery, my best example is you're doing a first metatarsal procedure, we need to still be considering at a minimum an oral anticoagulant if they have these risk factors. However, bigger risks include things like a procedure that's greater than 2 hours. You must be using something intravenously or IM. And then any kind of hip procedure. So this is general orthopedic components, and with hip arthroplasties and hip fractures, patients are at an even higher risk of developing blood clots. Okay, so here's the key point. I think this is my patient. She's got this cute little flower on her rollabout. But patients undergoing any isolated lower extremity orthopedic surgery that require immobilization, technically they don't require DVT prophylaxis as long as they can do 2 things. 1, ambulate early the day of the procedure. So technically, that Austin, you don't need to. But also that they can ambulate adequately. So the opposite limb is weight-bearing. They can flex and extend that knee that day. So we tell them, I want you to go home and rest. This is what I tell my patients. I want you to go home and rest. Put this up. You should be babied for the next few days. That's not fair to them. We need to make sure that we're adding that extra statement of, even though I'm telling you to rest and relax and not put so much weight on this, I want to keep the swelling down, you need to be able to flex and extend that knee at least 5 to 10 minutes every hour. We have to be adding this into our conversations with our patients. Okay, so non-orthopedic protocols, because they they happen as well. The duration of use will actually vary, but specifically abdominal procedures, anything in the pelvic area, or if they're trying to excise any type of cancerous lesion, because those patients are having that hypercoagulate risk there, they have to have it for greater than 4 weeks again. So they're looking at it for 30 plus days. And again, has to be started within 12 hours of the procedure. Aspirin is not enough. In fact, in many cases, Coumadin is not enough. We have to make sure that we're taking care of these patients. Okay, so specific agents that we should be using. Upper left-hand corner is our favorite. It's Lovenox. It's easy to use. It's pretty simple. Patients are relatively compliant with it, and it can be done at home in many cases. Up on the upper right-hand corner with heparin, obviously you're not going to have the patients use this at home as much unless they have some sort of home health care associated with it. The Arixtra, I don't utilize that much, but it's for patients that you are really concerned about some sort of like thrombin coagulation or issues like that. And then those oral anticoagulants. I'm using Xarelto a lot more in my patients to try to help with somebody that has a really high INR or things like that, but really being cautious and aware. Nowhere on this slide is the word aspirin. It does not count, and it's not part of what our protocol should be. Okay, so contraindications with it. If they've got an active bleed, you don't want to use the pharmacological agents. If their INR is greater than 1.5, and that should be tested within 2 to 6 hours of surgery. So in a lot of our cases, if we're doing acute trauma or we're concerned about, a non-planned procedure that we just have to go in and stabilize and correct, you still need to be catching this INR, because then you can justify why you did or didn't do something, 5 to 7 days down the road if they have an adverse event like a PE or even a DVT. So the thrombocytopenia, less than 100,000, and then if they've got a known bleeding disorder, you're not going to use the pharmacological agents, you'll simply use mechanical. Obviously, with mechanical, do you guys see this a lot where you go in, you're checking on a patient postoperatively, they've got terrible venous stasis on the opposite limb, you had to do something on this other extremity, and they've got compression on the opposite side, and it's causing skin, like lacerations and issues. Have you seen that before? I think we all have. I mean, we just need to be careful to be very vocal and advocating for our patients because the hospitals have their protocol and they're like, ooh, this person checks all these boxes. They need to have the SCDs. No, they don't. If their skin is too friable, that actually could make the situation worse or potentially open them up for a nidus of infection. And the same thing goes, if they've got any kind of lower extremity skin breakdown at all, they should not be having any kind of mechanical compression. Okay, so complications. Specifically for PE, it'll occur in 1/3 of DVT patients no matter what we do. Whether we catch it in time, whether anything like that, you're going to get a PE. It's how we treat it and how we can break up that clot so that they don't have a mortality issue. Patients will also develop this pulmonary hypertension post-PE. So we do want to try to stop it before it gets to your lungs. The most interesting part, though, is when you have a DVT, if you get one, you're going to get post-thrombotic syndrome. It's a fact. Patients are not going to recover well from these once they've had them. So that includes lymphedema, pain, they'll have this discoloration, they're going to complain of itching months to years down the road, and they're going to start to develop these venous ulcers, which brings us to our wound care conversations. I think the biggest thing that we need to just have a take-home point is this, that DVT by itself, if we're not prophylaxing against it, it increases your risk of PE by 50%. If we manage to prophylax against it, the decrease of that risk is up to 80% in a planned surgical setting. Where there's an interesting caveat to this is if you catch it and you're doing this planned prophylaxis in just a medically hospitalized patient, like they didn't necessarily have a procedure or even trauma, they were hospitalized for pneumonia or something like that, the risk of mortality actually doesn't decrease at the same rate as it does with our surgical patients. Those patients are already so much sicker, it's such a higher risk that it circumcedes and it actually doesn't allow for that same kind of assistance that we have with it. Okay, so that's my whole crew right there. My only other statistic that I really want to share with you guys is just that of a personal anecdote of when you have a patient that has one or you're concerned about high risk with a DVT or a PE. It's never, ever okay to not send them over to the hospital to get tested. And I think you might, but I'm not sure. I know I've seen a couple of times clinically in my practice and with my associate physician, and even back in residency, if you think it could be, it is, and you should get them taken care of. I mean, these happen to anyone. They can happen to young women, they can happen to an elderly gentleman, and it's something that we need to be taking seriously and speaking up as advocates for our patients. So with that, I'll take any questions. Yep, Dr. Bellis?
So up to 40% of DVTs can be silent.
Correct.
I would challenge that we not do a good job at screening people before they get surgery, so that I don't know how many of these patients who have DVTs after, especially elective ambulatory surgeries, already
Were there
have
before.
DVT going into it. So
Right.
I think that would be a great study.
Yeah.
To do a screening of pre-op patients to see if there would be DVT.
So Dr. Bellis's commentary is simply this, that patients will be asymptomatic in up to 40% of the cases of having a known DVT or a diagnosed DVT after the fact. And we are not, and I agree with you, we are, as podiatric physicians and surgeons, we're not doing a good enough job of screening them prior to surgery, and really having that being part of our informed consent. But I agree with you, a good study would be how many of these patients, because of these risk factors, they either already had one or were at such a high risk, it should have just been a known complication for that particular patient. Not to say that you wouldn't perform the procedure, but saying because of what high risk you are, we need to make sure that we're doing X, Y, and Z. I know it's a pain to be doing these injections every 12 hours, but it's for your life. I agree. Yes, sir.
The direct oral anticoagulants. Are you worried about bleeding at the time of surgery
Right.
at all?
So typically what they'll recommend, or at least current protocols are to start those medications about 12 to 24 hours post-operatively. Where we run into a problem, I think, is that we typically, we get lazy. Like, oh, just start that medicine tomorrow or take that aspirin tomorrow, when we really should be very vigilant about stating to them, whatever we're choosing for their prophylaxis, you need to begin this. Surgery ended at noon, you need to have your first dose by midnight. I know you're going to bleed a little bit. I recognize that.
Yeah.
We need to protect you.
Okay.
Yes, sir.
I have one question. First question is this ultrasound, Doppler ultrasound is a very operative dependent. So there's many times a patient comes really testing clinically positive for a possible DVT. It's there somewhere, and they'll give you back, oh, this is negative DVT. And it's terribly problematic for me because I think really there's a DVT. And the primary care goes by that text, sending the patient to you thinking that it's a leg or lower extremity problem versus it really look like a medicine problem is a DVT. So that's one question. The other question, what if your patient is already on aspirin? You know, we have a big committee of cardiac disease patients that are aspirin or bladder. You add up to that some Nivonox, and you're going to probably bleed in the brain or some bleeding somewhere. So what do you do with those?
So I think to address your first commentary, which is simply that there's a fair amount of, I wouldn't call user error, I would say user specificity of someone reading a screen for a duplex ultrasound for possibility of DVT. That does go back to the local hospital and to the radiology team as well. I mean, they need to be aware and conscious of it. I've seen, and perhaps we all could comment on this, that they tend to err on the side of saying it could be versus a no. I'll see that a lot on my reports where they're like, well, no specific evidence, but it could be, and please correspond or correlate with clinical findings or issues like that. So even when I get a report back like that, I'm still treating them prophylactically for a DVT at that point. I think to challenge back at your commentary about that it's a medical management part, that is part of what we do as well. And if we're the surgeon and we're taking care of them, and the expectation would be if our local friendly orthopedic surgeon was treating them for the hip fracture, it is their responsibility to prophylax them against DVT for any of these issues. So what I would say is we need to be very careful about giving them the risks when it comes to any kind of bleeding. But there have been only a few studies that have shown that a combination, your specific combination of aspirin and then Plavix, they would often switch from the Plavix to like a Coumadin or a Xarelto. So it wouldn't increase the risk significantly, but there's always a risk of bleeding. We have to tell them to be very careful post-operatively, no matter what we're doing. We don't want them to fall. We don't want them to have issues in general. But it outweighs the risk.
No, but if they're mixing both,
Correct. I'm saying that we would switch them. We would switch them from an aspirin Plavix combination to a low molecular weight heparin. Yeah, I would switch them to a Lovenox sub-Q. I'd have them switch it completely. Just for the short term. And again, this is us, the risk of them falling and bleeding versus the risk of them developing a DVT, leading to a PE, leading to death is so minute that we have to be protecting them and even ourselves against that potential complication. Yes, ma'am.
So, you know, I routinely use Lovenox,
Mm-hmm.
post-operatively, and one of the advantages I would do, I would have the nurse do the first step in recovery to both teach and start the prophylaxis. I've actually switched to Eliquis now, but what I've found is you have to use hot fluid, like we're going to low molecular weight heparin, Lovenox, but people are doing full anticoagulation with the orals, and I think that does have to be capped as well, otherwise I think the bleeding is
Absolutely. So her commentary was simply that if you're going to be using a sub-Q or an IM, low molecular weight heparin post-operatively, that it's not even so much that the dosage is halved, it's that it's simply that the mechanism of action with which it's using is a little bit more appropriate post-operatively so that we're not increasing the risk of having their INRs skyrocket. The oral anticoagulants, and that's where I think there is a little bit of a gray area, but I mean, just like Dr. Garafalos was speaking about earlier with gout, we do know this information and we can be aware it's not difficult for us to order something like an INR and then work with the family physician and the primary care doctors to make sure that they're properly anticoagulated. But typically now we should be more so post-operatively using those medications that are going to be the low molecular weight heparins versus the orals. We really should be staying away from the oral medications simply because there's more control for us as far as making sure that they don't become too anticoagulated.
I'll give you my 2 cents. And,
Of course.
Working at the University of Pittsburgh with a lot of orthopedic guys, that American College of Chest Physicians a few years ago, they have amended and aspirin is back on. Because a lot of orthopedic guys use aspirin. It's been that way for a long time. So that is back on the American College of Chest Physicians guidelines.
As a combination therapy, yes.
Right. So
Yep.
the other part is, most of this, like anything, is understanding, who is at risk. It's almost every single person. But the largest study on DVT that I know for foot and ankle is from our institution, and it's 0.7%. So you're going to get 1 or 2 here and there for sure. So diagnosing is obviously important. There are issues with that. So distal to the knee, we have trouble. Now, most of the time, those are ambulatory. So those are ambulatory, can be treated ambulatory. What you're looking for, obviously, are more proximal, because those are the ones that really cause trouble. The other part is, if you get crazy and you start doing everything else, the complication rate, does anyone know what complication rate of Lovenox is?
It's almost 4 to 6%. Yeah.
So now you get crazy and you start giving everyone Lovenox, you actually have now 4 times the amount of trouble that you had before. So it doesn't mean you shouldn't be doing it, but it is absolutely kind of figuring out who is at risk, trying to figure out who's the best candidate,
Right.
how to do it at, and paying attention afterwards whenever they crop up and diagnosing, because like most things, misdiagnosis is a huge problem.
Correct. And I think the most important statement that you made is simply that that we're not assessing that risk of our patients ahead of time, that we're not evaluating it, and we're not making sure that we're at least having that conversation with them, that they're aware of it. Yes, but agreed. Yeah, aspirin is part of a combination therapy. It should not be used as a singular medication to protect against DVT. Yes, sir.
Yeah, so based on your work and your personal work, how aggressive are you with the, let's say, over 60 who has a uncomplicated physical fracture, you get or a cast, or even a cam move, and maybe say the first 3 or 4 weeks you're keeping on weight bearing.
Okay.
I personally have been to a conference some years ago
I think the patient in your example, you said a 60-year-old male, I'm assuming, anybody. So 60-year-old who does, and they're weight bearing in this boot, is- I think it makes a little bit of a difference. I'm trying to, in my head, figure out, okay, how many risk factors do I have? It would vary depending on what they said to that social and family history. If they were describing, yes, my mom's had a DVT or this, or I've had one in the past, or their leg is huge and they've got terrible venous stasis in their extremity, I'm going to prophylax that patient. Versus one that is active, older person, but active, non-smoker, not obese, no issues, I'm probably not going to prophylax them, but we still should be having that conversation with them about it because everyone is at least at a minute risk of it.
I agree with that, but there are those who are pushing, and I don't know if that was a HICA, lecture,
Yeah.
they're
They're there to protect us. Like, they are.
But, what about the active FASPS
Right.
project for 4 weeks?
The 3 times
Unless they have a lot of
risk factors. The statement is simply if there are more than 3. If there's more than 3 risk factors based on that study, or on that list, then we should be prophylaxing against DVT. But I think just to remember, think about, we all raised our hands of a patient that's had a DVT. Think about who that patient was. 2 of the 3 that I've had were non-surgical. They were just trauma. They just had trauma. They were immobilized for some reason or anything like that. And the one that was surgical occurred 6 weeks after the procedure, traveling. So we just need to make sure that we're not discounting those younger patients either, that they are still at risk and they should at least have that conversation.
Thanks, Dr. Lockwood.
Thank you.
As-